Good morning, friends. So, this morning we are going to discuss management of heart failure in children beyond the guidelines. With me is a panel of eminent pediatric cardiologists. We have Professor Anita Saxena from All India Institute of Medical Sciences, Delhi. We have Dr. Snehal Kulkarni from Kokilaben Ambani Hospital, Mumbai. And we have Sumitra Venkatesh from Children's Hospital, Wadia Children's Hospital, Mumbai. I think we'll start with Anita. I would like to start by asking you as to how the heart failure seen in children differs from that in adults, because as you know, this is an adult meeting. So I would like you to emphasize what are the various issues which separates children with heart failure from adults with heart failure.
Okay, so I think it's children heart failure is very different from the adult heart failure, and the first difference is in the underlying cause. Children are fortunate because they have most of the time conditions which they can actually be cured, and therefore they are cured of heart failure. So it's not like an ongoing disease like in most of the adults. For example, congenital heart disease, that is the defects of the heart which are present at birth, are a major chunk of heart failure cases, and in majority of these cases you can actually fix the problem by either operation or by some intervention, and the children are actually cured, or let's say the heart failure goes away forever. So that way I think they're lucky. The less common causes in, at least in our country, would be conditions like rheumatic heart disease, which is a disease which affects mostly the age group of 5 to 15 years, and again here, because of marked leaking of a valve or obstruction to a valve, you can actually intervene and again resolve their heart failure. Yes, there will be still a percentage of patients who would have an ongoing heart failure because of so-called dilated cardiomyopathy, which is a heart muscle disease, which in many cases is not curable. So I think I would say majority of these children have a heart failure secondary to a disease which can be tackled.
Correct. The second issue I wanted to ask you, Anita, is that in adults, isolated right heart failure is quite uncommon, excepting maybe in restrictive cardiomyopathies affecting the RV.
Right.
Unlike in children or adolescents, to be more particular, that many of these patients following surgeries on their right ventricular outflow tract present with heart failure. So would you like to elaborate on that aspect of heart failure in children?
Yes, I think it makes it a little more complicated compared to adults, because right ventricular failure is a problem more often seen in children, or let's say adolescents, as you said, after a cardiac surgery specifically. We have a lot of drugs for heart failure, but actually none of these have been tested for right ventricular failure. So that makes it a little more complicated. We are using the same drugs that we use for left ventricular failure, for the right ventricular failure also. We don't know whether it's going to be the right thing or not. But I think we need more data to say that group of patients with predominantly right ventricular failure would be benefited by these drugs, or there are some alternate drugs that we require.
Okay, Snehal, I would like to move on to you now. As Anita said, that there are many conditions in children which can be actually treated. So if a child comes to you with a syndrome of heart failure, how do you go about evaluating this child, trying to pick up causes which can be treated?
I think even the history-wise, we need to go into the details. Even sometimes simple things like refusal to accept feed, excessive irritability. I think these kind of symptoms which we see more common in this kind of age group. And if you see clinical evaluation, as you have rightly said in your questionnaire, evaluation of the pulse is the most important thing. And that's many times not done properly. If you have a child which is a little collapsed child with all peripheral pulses are poor, just make sure that you may be dealing with a child with a severe left ventricular outflow obstruction. You have upper limb pulses bounding, lower limb pulses not palpable, obviously you are dealing with a severe coarctation of aorta. The third thing is, if you have all very bounding all pulsations, you may be dealing with a heart failure secondary to very large left to right shunt at the aortopulmonary level. And the fourth thing, you have inappropriate tachycardia for the child's condition. If a child is sleeping but you have a heart rates of more than 200, many times it may not be the effect, it may be a cause also. And some rare kind of tachycardias like atrial tachycardias or PZRTs may be responsible for heart failure. So these kind of things on clinical evaluation, I think needs to be very, very carefully evaluated. And if you have appropriate blood pressure equipment to measure the blood pressure in the upper limb and the lower limb, that will be another clue to diagnose the underlying kind of a condition.
Now, beyond clinical evaluation, what is the role of ECG, X-ray, echocardiogram, and maybe even other imaging modalities if you want to elaborate?
Yeah, I think because as been discussed, we have to rule out treatable causes in this age group, and that's the most important thing, because if you label them as dilated cardiomyopathy, I think we know that there are very limited medications, and what's the future we do not know. ECG actually makes a very important diagnostic tool. First thing is ruling out tachycardia as a cause of cardiomyopathy. We have some conditions like abnormal origin of left coronary artery from pulmonary artery, where the ECG plays a very important role for diagnosis. We have deep Q waves in the lateral leads with STT changes, which may be suggestive of Al-Kappa. And of course, a detailed echocardiography has to be done to rule out certain things which can be missed many times, and that is, first thing is a severe left ventricular outflow tract obstructions like aortic stenosis or coarctations. And unfortunately, we may not get good gradients if your LV function is significantly decreased.
I think that is quite important.
Yeah, and therefore we may miss critical aortic stenosis if you have impaired left ventricular function, and that can go unnoticed. The same thing like severe coarctation of aorta needs to be really looked in. Again, the gradients may be falsely negative or less, but that needs to be, I think, interpreted in view of the clinical condition. So echocardiography plays a very important role. And second thing is origin of coronary arteries. If you have on echo dilated heart with calcified papillary muscles with some degree of mitral regurgitation or evidence of EFs on echocardiography, see to it that it may be secondary to endocardial ischemia throughout, even going on through the fetal life. And unless we look for coronaries and left ventricular outflow tract very carefully, don't give a diagnosis of the dilated cardiomyopathy in this age group.
Because the beauty of these cases in children, tachycardiomyopathy, left ventricular outflow tract obstructions, Al-Kappa, is that if you fix their mechanical problem, the outcome can be completely
normal.
And they could have, much better quality of life and even near normal longevity.
And many times we do have excellent echo windows and good probes, so we can just make this diagnosis on echo. But if you have any doubt, I think we can have a CT to get the diagnosis.
Absolutely,
clear.
and the thing is that as an echocardiographer, you must have a fixed protocol and
to
you
evaluate.
must know to look for what and to look where. So that's a very important aspect. Okay, so having talked about the mechanical issues, I think let's move on to another subset, which is also quite unique to heart failure in children, and that's the metabolic subset. Right. So, Sumitra, can you tell us something about the metabolic abnormalities which can result into heart failure, and maybe some of your experience on vitamin D deficiency induced heart failure or cardiomyopathies?
Right. So as Dr. Saxena and Dr. Kulkarni rightly pointed out that we have structural defects which cause failure, this is one huge subset of dilated cardiomyopathy that we see in the pediatric population. So in my experience in Wadia Children's Hospital itself, we have a complete set of neurometabolic conditions, like starting from DMDs, Duchenne's muscular dystrophy, to the ones with Friedreich's ataxias, also coming with dilated cardiomyopathies and HOCMs coming in syndromic children. And this special subset, again, a treatable cardiomyopathy would be a hypocalcemia or a vitamin D deficiency induced dilated cardiomyopathy. So interestingly, we did a study. It was a small number. It was more like a pilot study that we did of 50 children, where we took up vitamin D deficiency rickets, proven vitamin D deficiency ricket cases, and we did their cardiovascular profile. So we definitely couldn't do the pro-NT-BMP and all those newer biomarkers, because this was done quite some time back and financial constraints. But we did see that the ones there was no clinical, the hormonal correlation. So we had about 50 children, out of which nearly 50% had LV sizes which were dilated, out of which 4 came with overt cardiac failure with a clinical dilated cardiomyopathy and myocardial failure requiring ICU admission, requiring inotropes and all the works. But beautifully, all of them had hypocalcemia, which was vitamin D deficiency induced. So the minute you start them on calcium therapy, within a follow-up period of about 8 weeks to maybe 10 weeks, most of them had normalized in their functions. We lost just one child with a dilated cardiomyopathy subset, but a beautiful response. And I would like to mention here that the old regime of 6 lakhs of Stowe's regime of vitamin D is now obsolete in children. So we no longer give 6 lakh units. Children, pediatric population, we stick to 3 lakhs. And if there are infants less than 1 year, where we see this subset most common, because in our study we had 3 to 6 months age group being the most common children having the problem. So we have seen that you just have to give them 2000 international units every day for 4 months. So that is like giving half the dose, like 3 lakh units, and then the RDA. So that's the dose.
My question to you is that if you get a patient who appears like a dilated cardiomyopathy, what will be your metabolic workup? Which are the basic tests that you would like to advise?
Correct.
And also in terms of therapeutics, which are the supplements that you would like to add, irrespective of having obtained the results on their metabolic profile?
Perfect. So the baseline metabolic profile that we do would definitely include a CBC to look at anemia and all the other this thing. Apart from CBC, we would be looking at metabolic profiles like electrolytes, because we've seen potassium, sodium playing a very important role. We do the ionic calcium, the serum calcium levels. We do the vitamin D levels. A lot of them, if they are affording, also get the PTH, and that will be the isolated the PTH hormone levels. We also do, just to be on a safer side, we do a CPK-CPK-MB ratio to rule out an acute, because these children usually have a couple of days of viral prodrome and then they come to us and they're picked up on things. So CHOP-T, and that will also be included. We also definitely do a random blood sugar monitoring and urine for reducing substances. We look for acidosis on their blood gases, because these are and ammonia levels. So these are the baseline metabolic profile that we definitely do for all children who appear to us with a cardiac dilated cardiomyopathy subset.
And one more thing I wanted to, even I would like your opinion on this. What I have seen is that we think that hypertension is a problem only of adults, but we have seen quite a few babies who come with left ventricular dysfunction following hypertension, including infants. Right. And my question is, what happens is when they come to the ICU, their hypertension is decapitated because of severe LV dysfunction. Unfortunately, at the time of discharge, nobody records their blood pressure, and that blood pressure goes undetected for quite some time. So I think it's a good idea, apart from adding all this ECG, good echo, metabolic profile, I think even taking a blood pressure in a child who comes with heart failure would make sense. What do you think, Anita?
I think it's a very valid point. In fact, we've just reported in one of the journals that the prevalence of hypertension is not as low as we think it to be. And in our study, we found it either systolic or diastolic hypertension was present in more than 10% of school children that we screened, and this is like 15,000 children that we screened. So I think it's a very good idea, and you have absolutely rightly said that when the left ventricular function is bad, then you miss hypertension. And we have again presented our data on ACC, where we showed that all the pulses were weak, so hypertension was never picked up, and even a pressure of 130/80, which looks really mild, in a patient who's in failure may mean significant hypertension.
Absolutely.
And the group that we studied was that of aortoarteritis. So aortoarteritis, because of renal artery stenosis, these patients come with flash pulmonary edema. They are in gross heart failure. They are very tachypneic, their pressures are low, their pulses are weak, and only when you actually treat them, make them better, that they start showing hypertension. So I think it's a disease that is kind of not diagnosed now.
And I think, nowadays, looking at the fundus has gone out of fashion, and sometimes there may be telltale signs, fundoscopic changes, left ventricular hypertrophy, which may give you a clue.
And I think a lot of people say we don't have a pediatric cuff, so we can't check the blood pressure.
I don't think, that's a good argument. Okay, let's come on to some of the pharmacological interventions in children with heart failure. So as you said in the morning, that ACE inhibitors or angiotensin receptor blockers, beta blockers are the mainstay, and then diuretics, depending upon the symptomatic status of the. What I want to know from you is, which you obviously spoke about in the morning, what is your experience with sacubitril and valsartan combination, which is making a big news in the adult world? So what is, I know that we don't have sufficient data, but I would like to know What is your gut feeling as to how this combination is going to work in children?
I think it's going to work. It may not work as well as it worked in adults, where everything seemed to have gone favorably in favor of RNA, the combination that you talked about. But I think it is going to have its place in a number of cases, for example, cardiomyopathies. And I think we have used it very infrequently. I met one of our colleague, Dr. Suresh, who said that he has used in 4 patients who are above 6 years of age with dilated cardiomyopathy, and he found it to be very useful. But I think we'll have to wait for the result of Panorama heart failure trial. Paradigm heart failure trial has really changed the paradigm now, and everybody thinks it has to be #1 drug, and in fact it has become class 1 drug now in adults. I think it's going to be useful in children. I'm not so sure about, let's say, children below 1 year of age, but definitely in 6 years and above, I think it's going to be helpful.
Another intervention, I mean, I wouldn't call it necessarily pharmacological, but by virtue of, some kind of medicinal treatment. Snehal is in acute heart failures. It's always a dilemma when a patient comes to you for the first time with the heart failure, history is only 2 or 3 weeks, whether this is myocarditis and the role of intravenous immunoglobulins. So how do you assess your patients as to whether they are going to be responders or otherwise?
What
has been your experience?
Yeah, it's difficult, and its role is always controversial in the literature. By and large, as a clinical guideline, we take it if the history is acute, which is less than 3 months. We usually give IVIG as a part of our initial protocol. If it is a bigger, and it's very difficult to get a history of throat infections or just any kind of a viral prodrome in a child. If we get it, it's fine, but if we don't get, by and large, this is a clinical guideline we follow to give IVIG with an acute history. On echocardiography, I feel that if your ventricles are not very dilated, your ventricular mass thickness is preserved, there is a high possibility that it's of acute origin, then it's a very chronic, where you see in some patients with a very dilated, thinned out ventricles and thinned out ventricular septum and the posterior wall, you know that it's of very long duration, and I don't think giving IVIG is of any.
Probably it's a burnt out disease.
Burnt out disease. Rather than acute history with a preserved wall thickness and a ventricular volume, I feel this may be of acute origin, and it's worth giving IVIG.
In your practice, before giving IVIG or calling it a myocarditis, is it a practice to do viral markers or doing an endomyocardial biopsy, or you just go clinically?
It's more clinical in my setup where I practice, but initially, yes, there was a study being done at NIV Pune where they were taking samples, the blood samples for testing for Coxsackie and echoviruses, which were known to cause myocarditis, the most common causes of viruses. So they were doing a study when we would send it to them. Now they've stopped doing it, so now we no longer send a vital marker for sure. But as I said, troponin T and CPK and CPK-MB ratio does give us a clue, and obviously the echo picture does give us a clue as to whether it's acute or more chronic.
Anita, let's talk about a drug which you referred to in the morning as well, since you come from the same generation that as I do, is Digoxin. Whether, in your opinion, it should be relegated to the books of history, or you still think that in children with heart failure, with or without left ventricular dysfunction, Digoxin still has a role to play?
I personally think it still has a role to play in some specific circumstances. It's not the drug that I use first, which I used to write as #1, let's say 20-25 years ago. There has been some data of increased mortality with Digoxin, so we need to be very careful. But what I like about Digoxin is first that its toxicity in children is much less common compared to adults. They have a much better therapeutic range, and therefore you could use higher doses relatively. The second thing is that patients who have marked tachycardia, whether it is because of sinus tachycardia, whether it is because of heart failure or any other reason, I think Digoxin does play a role. Patients who have arrhythmias, Digoxin I still believe is a very good drug in children, and for a, let's say, straightforward case of supraventricular tachycardia, we are still using Digoxin and beta blockers as a combination rather than sending them over to ablation, because they are usually small, too small for any drastic interventional treatment. So I think it still has a role, but I would put it as #4, and I would put ACE inhibitor, diuretics and beta blockers ahead of Digoxin. But yes, I think the prescription in my own practice of heart failure, Digoxin would perhaps be prescribed in less than 10% of cases.
In less than 10%?
Less than 10%. Interesting.
What is your...
Yeah, I think the same thing. But I think sometimes these children have some inappropriate tachycardias with dilated ventricle, with the sympathetic overactivity. I feel still digoxin should be considered. When they come in an acute situation, I'm a little concerned giving beta blockers as a first drug. So I think digoxin may be a better drug.
Me too.
Yeah, so even in our generation, we still use
Yeah.
Digoxin.
So another area of pharmacotherapy in children which needs some attention is a role of anticoagulants. As you know, patients with severely impaired left ventricular function can develop thromboembolic episodes, and if it's a stroke, it can really have very serious consequences on the quality of life. So what I want to know, but then on the other hand, children may fall, may hurt themselves, bleed somewhere. Monitoring is quite a difficult task in children. So I want to know from all three of you as to what has been your practice as far as anticoagulants are concerned. Do you use them at all? And if you use them, whether you are fond of using NOACs or whether you are happy with warfarin, what is the status?
So let me answer the last part of your question first. NOACs is something I don't use in children. I think their utility in children is still to be proven. It is supposed to be the best drug in adults because it doesn't require monitoring, but to my belief, there is no drug that does not require monitoring. So I wouldn't go for NOACs till we have some data. The criteria for using anticoagulation, oral anticoagulation, which in my case will be either warfarin or acetone, that is one of the vitamin K antagonists, would be a very low ejection fraction. So I would use it if it is less than 15%. I am more aggressive with right heart failure to use anticoagulation because they tend to have a lot of spontaneous echocontrast in right atrium and right ventricle, and I think they're very prone for thrombosis. Or else a patient who has already shown a thrombus in the left ventricle, I would use it even after the thrombus has resolved.
Right.
And my INR maintenance would be between 2 and 3. And yes, it's quite a tough deal to deal with INR in small children because doing repeated sampling is quite difficult.
Yeah.
But I guess that's the best we can get to.
Snehal.
I think the same with him. Our threshold of starting anticoagulants is quite high.
Yeah.
And unless it's really very low ejection fraction or any thrombotic or embolic episode, I don't think we will like to start.
Well, it'll be same. Less than 15% is when we started.
So some people, as a via media, are using antiplatelets. I'm not sure whether antiplatelets is a great strategy. What do you think?
I think the mechanism of thrombus is not platelet, and therefore to use platelet alone, I mean, there are people who would rather combine anticoagulation with antiplatelet, for example, after a valve replacement. But I think using antiplatelet is not the right, not a scientific way of treating a thrombus.
So, I mean, before we conclude, I think we need to talk about some of the other interventions in heart failure which are quite popular in adults, like devices. So, what has been your experience with devices, both only bi-V pacing and the combo devices with AICDs?
So there are two issues. One is that we don't have much data with devices in children. Data is coming up, and I would say there is more data between 12 and 18 years of age. We can call them children, but less than 12 years the data is limited. The reason being that these devices are relatively bulky. They require 2 leads to be put in, and therefore you have to have a child who is more than 15 or 16 or 18 kilos of weight. And secondly, although you can put epicardial leads also if required. And the second thing is that we really have to show dyssynchrony in the ventricle to them to be effective, because I think data in adults has clearly shown that unless there is dyssynchrony within the ventricle, these devices may not be very helpful. So I showed one slide on a sort of a review of ICDs and CRTs in children and adolescents, and I think the authors kind of concluded that in a given case where you have dyssynchrony, where you have a heart which is unlikely to be reversing back to normal, that means you have something like dilated cardiomyopathy, and child is of a sufficient height and weight, I think CRT or bi-V pacing will perhaps have a role, but there is no sort of guideline to guide us, and we have to go by individual case-to-case basis.
And my other concerns, as you very rightly said, the size is so big, and the leads going across the tricuspid valve, causing long-term issues of the tricuspid valve, the thrombosis, thromboembolic complications, is something that we should be worried about. And as far as
The cost is another issue.
One thing I think, Bharat, I feel that it needs to be really looked into in our contest about the role of pulmonary artery banding in suitable situations, especially if the children are less than 2 or 3 years of age, because there is a data in more than 70 patients now. If your right ventricle is good on MRI, whether that can be considered as a bridge to transplant, where there are some reports that even the function of the left ventricle comes back to normal.
Yeah.
So I think that needs to be looked into in our kind of a...
Really, Dietmar Schranz, who is one of the pioneers, I had a long chat with him, and he is such a person who is willing to come to India and be a part of a program if one of us are willing to take it up as because we need to think about novel
out of box, out of box things,
in a country like ours.
Exactly, where these are cost is an inhibition.
And lastly is just a quick word on cardiac transplant before we conclude. So what is your take on cardiac transplant?
Right now, world over, that is the destination therapy that people are aiming at. So we buy time by putting them on medications, maybe out of box thinking, like doing a PA banding on dilated cardiomyopathy patients, and also putting LVADs. I think, having said that, maybe in our country with the sheer volume and the population, cardiac transplant would be a faster, faster therapy that is available rather than actually investing on LVADs. Here. So I think there are very few centers, as I know, can be corrected, which are doing pediatric heart transplants as a specialty.
And that is the case all over the world.
Correct,
Pediatric transplants are not done in the same number. And also it's important, pediatric transplants in a structurally normal heart otherwise is a different ball game. But if you are talking about dextrocardia or situs ambiguous, venous anomalies, only left SVC is so much of a problem for a surgeon when it comes to transplant. So I think transplant still remains a distal dream as far as...
I may just add that the good thing about pediatric transplant, especially dilated cardiomyopathy, is that you can actually put a bigger person's heart into the place. So the donor availability is not so restricted to children.
Right.
So if you have an 18 or 20-year-old, you can actually put the heart into a 6 or 7-year-old because there is a lot of space available.
Yeah, that's the...
Yeah, so I think with that we will conclude this session, and I take this opportunity to thank all three of you to have discussed some of these very relevant and important issues of managing cardiac failure in children, which is so very different, and that, as they say, for many other conditions, children are not miniaturized adults, and that's why therapy has to be different. Thank you.
Thank you.
Thank you.